Hi everyone, welcome to POC Nurse. My name is Gozi. In this video, we're going to discuss pneumothoraces for the respiratory section of the CCRN exam. We're also going to discuss hemothorax as well. What is a pneumothorax? A pneumothorax is accumulation of air in the chest. More specifically, it means accumulation of air in the pleural space. What types of pneumothoraces do we have? We have traumatic pneumothoraces and atraumatic pneumothoraces. Atraumatic pneumothoraces are usually spontaneous in nature, meaning there's no precipitating event. When we talk about spontaneous pneumothoraces, we have two types. We have primary spontaneous pneumothorax and secondary spontaneous pneumothorax. Primary spontaneous pneumothoraces usually happen in people with no underlying pulmonary disease. So they usually will affect tall, thin men because they have something called blebs in their lungs that I think are easy to rupture. So people like that would get primary spontaneous pneumothorax. People at risk for developing secondary spontaneous pneumothoraces usually have some underlying pulmonary disease. Some risk factors for developing a primary spontaneous pneumothorax are smoking. We already talked about the tall, thin men. Pregnancy, people with Marfan syndrome, and people that have a family history of pneumothorax. These people are at risk for primary spontaneous pneumothorax. Who is at risk for developing a secondary spontaneous pneumothorax? We talked about people that have some kind of underlying pulmonary disease. Some of these pulmonary diseases could be COPD, asthma, necrotizing pneumonia, tuberculosis, lung cancer, sarcoidosis, cystic fibrosis, idiopathic pulmonary fibrosis, severe ARDS, that's acute respiratory distress syndrome, people with some form of collagen vascular disease, and people that have thoracic endometriosis. So these are the two types of atraumatic pneumothorax. Now when we go to the other side and talk about traumatic pneumothorax, we're talking about closed pneumothorax, open pneumothorax, and iatrogenic pneumothorax. What is a closed pneumothorax? A closed pneumothorax is accumulation of air in the pleural space that is not communicating with the atmosphere. So there is no wound through the chest wall. So if this patient with a closed pneumothorax, if you look at the patient's chest, you won't see any opening on the chest. A patient with the open pneumothorax, on the other hand, will have an open wound on the chest all the way into the lungs. Meaning, in this case, the lungs will be communicating with the atmosphere. So air will go from the atmosphere through that wound and into the lungs. So that's closed pneumothorax and open pneumothorax. An iatrogenic pneumothorax occurs as a complication of a medical procedure. So maybe a patient is getting a lung biopsy done, and during that procedure the patient develops a pneumothorax. That will be an iatrogenic pneumothorax. So these three pneumothoraxes, the open, the closed, and the iatrogenic, fall under traumatic pneumothorax. So a closed pneumothorax can be caused by blunt trauma to the chest during something like a motor vehicle accident, falls, blows to the chest, or blast injury. CPR, cardiopulmonary resuscitation, that's compressions during CPR, can also cause a closed pneumothorax. Positive pressure mechanical ventilation can also cause a closed pneumothorax. What can cause an open pneumothorax? An open pneumothorax is caused usually by a penetrating wound to the chest. That's penetrating chest trauma. Something has gone from outside to the chest wall and into the lungs. Something like a knife, something like a stab wound will cause an open pneumothorax. So we said iatrogenic pneumothoraxes happen during medical procedures. So what are some of these medical procedures that could lead to an iatrogenic pneumothorax? Well, some of them are pleural biopsy, transbronchial lung biopsy, central venous catheter insertion. So when they are placing central lines, there is a risk of a pneumothorax occurring. Placement of a tracheostomy, intercostal nerve blocks, positive pressure ventilation, like we talked about before, can also cause iatrogenic pneumothoraces. So these are some causes of traumatic pneumothoraces that lead to closed, open, or iatrogenic pneumothoraces. We're now going to talk about tension pneumothorax. So what is a tension pneumothorax? A tension pneumothorax happens when air accumulates in the pleural space and there is no exit for that air to leave the pleural space, meaning this air continues to accumulate and apply pressure to the affected lungs, and then starts to apply pressure to the unaffected lungs and the mediastinum. So a tension pneumothorax is a life-threatening emergency. It's a medical emergency that needs immediate attention. And for your CCRN, it's usually bolded in the CCRN box. So it's something that we need to know about for the exam. And because of that, we're just going to talk about the treatment right away. So if you have a patient with a tension pneumothorax, the first thing that needs to be done is needle decompression before more definitive treatment. So if you get a question that says a tall thin male comes in with shortness of breath, pleuritic chest pain, history of family history of pneumothoraces, whatever, but you recognize that this patient has tension pneumothorax in the question, and the question says, what is the next thing to do for you to prepare for surgery, needle decompression, chest x-ray, CAT scan? You would want to pick needle decompression. That's the first thing you want to do. You want to relieve the pressure, the tension in the patient's lungs so that the lungs are able to start re-expanding. And if there's any mediastinal shift, you want to start to resolve that right away, because it could lead to respiratory arrest and cardiac arrest, including death. Another thing about the tension pneumothorax, if a patient has an open chest wound, an open pneumothorax, if you cover that wound totally, the patient could develop a tension pneumothorax. If the covering on that wound, meaning this is not addressing, this is just the skin that's over the wound, if that wound covering doesn't permit air to escape, the patient can develop a pneumothorax. So what you want to do in that case is place a dressing on this open wound. On 3 sides of the dressing, you would occlude it. That means you would tape 3 sides of the dressing down. The 4th side you would leave open so that would be the route for air to escape when the patient exhales. That way you could prevent a pneumothorax from happening in the first place. Still on the subject of, so you could prevent a tension pneumothorax from happening in the first place. I hope that was what I said before. Still on the topic of the tension pneumothorax, what could cause a tension pneumothorax about all the things we just spoke about? What actions could we take that could lead to a tension pneumothorax? Well, first is totally occluding that chest wound and causing air to accumulate. Secondly, if the patient has a chest drain in place, if we clamp that chest drain, we put the patient at risk of developing a tension pneumothorax. So we don't want to clamp the chest drain. So if you have a question on your CCRN exam talking about clamping the chest drain, just know the risks of what could occur if you clamp the chest drain. Patient could develop a tension pneumothorax. Also, you want to make sure that the tubing on the chest tube is not does not have any blood clots in it, because if it has clots, those clots could occlude the tubing, and then again air will not escape through the tubing and the patient could develop a tension pneumothorax. Furthermore, you want to make sure that there are also no kinks in the tubing. Essentially, you want to make sure that the tubing is not occluded in any way. It's not clamped, it's not kinked, it's not clotted. so that the patient doesn't develop a tension pneumothorax. So if you get a question about the tension pneumothorax, you'll be able to answer it, hopefully, as long as you know like what could cause a pneumothorax, what are those things that could cause it, like trauma, the iatrogenic causes and things like that, and what are the things that we at the bedside could do to cause it. So these are just a few things about tension pneumothorax that I wanted to mention now. I'll probably talk about them again as we move along, but I just wanted to bring your attention to it because it's something that the CCRN exam emphasizes on, so that you have it at the forefront of your mind. All right, we're going to move on now. Now we're going to talk about the signs and symptoms of a pneumothorax. And during this discussion, we're going to differentiate these symptoms from the spontaneous traumatic pneumothorax. We're going to differentiate those symptoms of those symptoms from that of a tension pneumothorax. So we're going to essentially say these are the symptoms when the patient has a tension pneumothorax, and these are the symptoms when a patient just has a spontaneous or traumatic pneumothorax that is not a tension pneumothorax, or that has not converted to a tension pneumothorax. Okay, so when a patient has a pneumothorax, either tension, spontaneous, or traumatic, we know they're going to have some form of respiratory distress depending on how severe the pneumothorax is. But with a tension pneumothorax, they are certainly going to show good signs of respiratory distress. So either way, in all of the above, they'll show some form of respiratory distress. They will probably display shortness of breath. Some patient may have some chest discomfort, pleuritic chest pain. So when they take a deep breath, they're going to have pain. When they are not breathing, they won't have any pain. That's pleuritic chest pain. That's one way to differentiate it from angina, which is chest pain of cardiac origin, in case you get that on a question. If it says pleuritic chest pain, has to do with the lungs. If it says angina, has to do with the heart. Now, the patient will also have asymmetric chest rise. So when the patient takes when the patient breathes, one part of the chest, the unaffected chest, will be higher than the other one when the patient has a significant amount of pneumothorax. The patient, of course, will be hypoxemic if the pneumothorax is large enough, but definitely with tension pneumothorax, they will be hypoxemic. Now, the patient will have decreased or absent breath sounds on the affected side. So the lung that is collapsing due to the pressure from the air in the lungs, that side will have decreased or absent breath sounds. Now, if the pneumothorax is a simple one, there will be no mediastinal shift. If it is a tension pneumothorax, there will be a mediastinal shift. I think this is now a good place to jump into the signs and symptoms of a tension pneumothorax. So in a tension pneumothorax, we will have mediastinal shift, meaning the air is going to accumulate so much on the affected side that it'll start to push the other lung. It'll start to squish the other lung, for lack of a better word. So now the affected lung is collapsed, the unaffected lung is getting squished, the heart is getting squished, the great vessels of the heart are getting squished, so your aorta is getting squished. The trachea is also being pushed towards the unaffected lung. So everything towards the unaffected lung is getting squished in a tension pneumothorax. What happens when both lungs are getting squished, getting collapsed? First, we're going to have severe hypoxia. There'll be severe hypoxemia. So the patient may look pale or even cyanotic. Secondly, the heart is getting squished. So you're going to get decreased cardiac output. If the heart is getting squished, it cannot pump. If it cannot pump, it can't send out blood to the bodies, which means the body is not going to get enough oxygen. Now, this patient is going to be hypotensive, blood pressure is going to be low. And because now the patient is getting hypoxemic, patient is going to get really tachycardic. The heart is going to be beating fast because obviously there's no oxygen going around the body, and the heart is trying to compensate and make up for that. So the patient is going to be tachycardic, patient is going to be hypotensive. Also, the patient will have distended neck veins. Why? So now the heart is being squished, the aorta is being squished, there's decreased cardiac output, so blood is not really leaving the heart. In the same vein, blood is also not particularly returning to the heart in a normal fashion. Why? Everything in the chest is getting squished. The lungs are getting squished. So how is the body going to return blood from the rest of the body to the heart that has now become a high pressure cavity, because you have all this air in there squishing everything and pushing everything? Venous return is going to drop. So if venous return drops, all of that blood has to be somewhere if it's not going back to the heart. So this is how you get the distended neck veins. I hope that makes sense. So it's very clear that this is a life-threatening condition that needs to be treated right away, like we talked about before, with needle decompression. Let's now talk about a hemothorax. So hemothorax, just like a pneumothorax, is the accumulation of something in the pleural space. In this case, it's blood. So hemothorax is the accumulation of blood in the pleural space. And you can get so much accumulation of blood in the pleural space that it causes collapse of the lungs. And it can also lead to shock, hypovolemic shock, if the bleeding is big enough. So hemothorax can be caused by blunt or penetrating trauma to the chest wall, the mediastinum, or lung tissue. It could be caused by lung cancer. It could be caused by anticoagulation therapy, and also iatrogenic causes, such as during the placement of a central line or a lung biopsy. Signs and symptoms of a hemothorax are similar to that of a pneumothorax in that you have absent breath sounds on the affected side, and you have the trachea. There may be deviation of the trachea towards the unaffected side. One difference between a hemothorax and a pneumothorax, if you talk about the signs and symptoms, is that when you percuss the chest in a hemothorax, you get a dull sound. In the case of a pneumothorax, you get hyperresonance because the chest is full of air. It is hyperinflated in a sense. Patient may also complain of chest pain with a hemothorax, shortness of breath. The patient might be tachycardic, hypotensive. Of course, we have asymmetric chest rise as well. We talked about diminished or absent breath sounds on the affected side. And the patient may have clinical symptoms, signs of shock if the patient is bleeding a lot. If the patient has bled greater than 4 mL of blood, we might start to see signs of shock. So how do we treat pneumothoraces and hemothoraces? Let's talk about hemothorax first, and then we'll jump into pneumothorax, since we have different kinds of pneumothorax and the different kinds may require different treatments. So for a pneumothorax, we have blood in the pleural space. So essentially, we want to drain that blood out. If the patient is bleeding, we want to stop the bleeding. So for the patient with a hemothorax, we want to place a chest tube to drain the blood out. Now, it's one thing to place the chest tube and the patient stops bleeding, and another to place the chest tube and there are indications that the patient is still bleeding. Now, the patient might need surgery to address the bleeding so that the hemothorax doesn't continue to take place and the lung is able to re-expand. So how do we know the patient is still bleeding after placing a chest tube? So when the chest tube is initially placed, if the patient puts out about 1500 mL of blood, the patient might be bleeding from some place that has not stopped bleeding. Patient might still be bleeding, so that patient might need surgery to address the bleeding. If the chest tube is placed and the patient puts out 250 mL of blood, in 2 hours. So the first hour you have 250, and the second you have 250. The patient might have a source of bleeding that has not resolved itself. So this patient might need surgery. So the patient with hemothorax, we have to do our airway, breathing, and circulation. We have to make sure the patient has a patent airway. If the patient is requiring oxygen, we may provide it by a nasal cannula. If the patient needs to be mechanically ventilated, we could intubate them and put them on the ventilator. We want to make sure that cardiac output is adequate for this patient. So if the patient needs fluids, we can give the patient fluids. We may also give patients like this a blood transfusion. If the patient is in pain, we can give narcotics on a schedule so that the patient, when these patients are in pain, they don't take deep breaths. So we need to address their pain so that they can take those deep breaths and keep their lungs expanded. For patients like this, we also want to monitor them for complications such as atelectasis and shock. Remembering that these patients could go into hypovolemic shock if their blood pressure starts to drop, they start to get altered. We need to keep an eye on them so that we can address shock fast before it gets too severe. So that's it for the patient with hemothorax. That's it for the treatment of the patient with hemothorax, what it is and what causes it. Now we're going to talk about treatment for the patient with pneumothorax. Remember, we have the spontaneous pneumothorax, we have the traumatic pneumothorax, and we have the tension pneumothorax. So if a patient has a small pneumothorax, they may be asymptomatic. So in patients like this, you want to observe. You may have to provide supplemental oxygen via nasal cannula. You want to observe them and see how they do, and they may require no treatment. They may require no treatment, and the pneumothorax could spontaneously resolve on its own. Now, talking about a spontaneous pneumothorax, if the patient is asymptomatic, we can observe the patient and let the pneumothorax resolve on its own. If the patient is symptomatic, the patient might require needle aspiration. The patient may need a chest tube to let that air escape and let the lungs re-expand. The patient may also get a procedure called pleurodesis done. Pleurodesis is a procedure where you fuse both the parietal and visceral pleura together. So basically, you're trying to close that pleural space to prevent future occurrences of a pneumothorax. It could be done chemically or it could be done mechanically. So chemically, you can do it by inserting solutions through a chest tube to irritate the area and cause the visceral and parietal pleura to fuse together or adhere together. Or it could be done surgically, where the surgeon goes in and mechanically kind of irritates both areas, the visceral and parietal pleura, to adhere together. For those patients with blebs, remember we said that in primary spontaneous pneumothoraxes, it could be due to blebs that some people have in their lungs. So a thoracotomy could be done to remove the apical blebs for these people that are prone to primary spontaneous pneumothoraxes. For the patient with a tension pneumothorax, the patient needs immediate decompression to prevent collapse of their cardiovascular system. So immediately you want to do needle decompression, and you want to insert a chest tube to let that air escape and let the lung re-expand and remove the pressure on the mediastinum, if any. Also, in the patient with an open pneumothorax, remember the patient with an open pneumothorax has an open chest wound on their chest. So you want to immediately close that wound. But remember, when you put the dressing on, you don't tape it on all four corners, assuming you're putting a square dressing. I think it's easier to understand that way. If you're putting any kind of dressing on the open wound, you have to leave room on some portion of the dressing for air to escape. So if you're doing a four-corner dressing, you would tape the dressing on 3 sides and leave the 4th side open. If your dressing has an irregular shape, you can tape it however you want to tape it all around, but don't tape it all the way around. Leave some space for air to escape when the patient exhales. This way, a tension pneumothorax will not happen. This way, there will be no accumulation of air in the pleural space with nowhere to go. This patient would also require insertion of a chest tube so that the lungs are able to re-expand, and surgery may be necessary to address the trauma that the patient was subjected to or has been through. So for all the patients with the pneumothorax, with the hemothorax, we want to do our airway breathing circulation. If the patient is requiring oxygen, we want to give it the best way to make sure that they are maintaining their O2 sat either by nasal cannula or by mechanical ventilation. We want to support circulation by giving blood, by giving fluids, by maintaining their blood pressure with medication, or anything we need to do to maintain their circulation. For oxygenation and ventilation, we can use positioning to make sure that the patient is getting adequately oxygenated. So if the patient has had surgery on one lung, like a thoracotomy, we want to put the good lung down. We want to use positioning such as putting the patient in a semi-fowler position to make sure that they are ventilating the best that they can. We want to also medicate for pain so that the patients can actually breathe. They can actually perform the motion of breathing through the pain that they are having, if they have any pain. And finally, because these pneumothoraces can convert to a tension pneumothorax, can lead to shock and circulatory collapse, we want to monitor the patients for complications. So we want to monitor the patients for complications such as shock, cardiac arrest, atelectasis, and so on and so forth. This is where we're going to end the video on pneumothorax and hemothorax for the CCRN exam. I hope you found the video helpful. My little son is here with me. He's talking from time to time, but I hope you still find this video helpful. Please like, share, and subscribe, and I will see you in the next video. Bye bye now.